Hello, everyone. Good morning, good afternoon, and good evening. On behalf of USAID Advancing Nutrition and the University of North Carolina, thank you for joining the third Family Inclusion in Nutrition through Engagement Community Practice, or the FINE COP for short. My name is Neha Javeri, and I am a Social and Behavior Change Specialist for USAID Advancing Nutrition. If you've not done so already, please start off by using the chat box to introduce yourself, including your name, organization, and country you're joining from. So today's session will focus on engaging family members in formative research. We have a few questions prepared for our speakers, and we hope to hear from you all as well. So we will leave time at the end for questions and discussion. I will now take the opportunity to introduce our speakers. So first, we have Dr. Siddharudha Shivalli, who is a primary care and family physician and a public health expert from India. He is a trained public health leader fellow from the Rollins School of Public Health in Emory, and he is working at the core of public health and adding value through translational science. Currently, he is an assistant professor in epidemiology and co-deputy director, the Center for Evaluation at the London School of Hygiene and Tropical Medicine in London. Before joining LSHTM, he worked as the regional technical advisor in Southeast Asia for TEFINET. He has taught epidemiology and public health to medical students and MD resident doctors in India for the last 10 years, and epidemiology in the UK for the previous 3.5 years. His research focuses on improving primary and secondary healthcare, particularly maternal and child health, and evaluating complex public health interventions in India and similar countries. Next, we have Tulani Matenga, who is a PhD candidate at the University of Zambia School of Public Health, and a qualitative research fellow at the Center for Infectious Disease Research in Zambia. His research cuts across several disciplines, including HIV/AIDS, maternal and child health, health promotion, and community resilience, as well as power dynamics in healthcare, and now more recently, nutrition. His scholarly work focuses on male involvement in the prevention of mother-to-child transmission of HIV and involving family members in child health. He also serves as a teaching assistant in the Department of Health Promotion and a study manager at UNC Global Projects Zambia. And last but not least, we have Mackson Maphosa, who is an SPC advisor for the Amalima Loco Food Security and Resilience activity in Zimbabwe. He designed and led the Male Champions activity and has years of experience in SPC and communication and social marketing. He received his master's in public health from the University of Witwatersrand. Thank you all for being here and welcome. And now I will turn it over to our speakers to answer a few questions. So please start off by describing the research context where your work takes place, what worked well during the process of conducting research with your family members. And yeah, we'd love to hear from you. I will turn it over now to Dr. Shivalli, then we will hear from Tulani, and then we'll hear from Max. Thank you all. Dr. Shivalli, sorry to interrupt. I believe you're on mute in case you've begun talking.
Oh, sorry. Yeah, can you hear me now?
Yes, we can.
Okay, thank you. Hello, everyone. To give a brief research context, this research was done in India, the northern part of India. Like any other low and mid-income country, India has been having the issue of anemia during pregnancy and poor weight gain during pregnancy, and that has been there for a long time, and even after inception of National Rural Health Mission, where there are a lot of cash incentivization, but the question of poor gestational weight gain and poor compliance to iron folic acid, it's still persisting. So we identified this problem, and India being a very diverse country, some of the states are very poorly performing, and this study was done in one of the poorly performing states in India, that is Uttar Pradesh. So we thought of designing an intervention which can be adopted locally and try to address these issues, from a qualitative aspect. So we came across the Manoff Group's TIPS approach. It stands for Trials for Improved Practices. Maybe Mac can talk more on that. So it actually has two parts, two components. One is the assessment phase, where it involves mainly the qualitative research, and we did, and we involve families, and the intervention part where we implement tips. So this is the brief research context, and we wanted to implement whether this would bring an improvement in the gestational weight gain and also a reduction in maternal anemia during pregnancy. So what worked well during the process of research with the family members, the qualitative component, the assessment part was very important, where we conducted the focus group discussions with pregnant women, the obvious beneficiaries, and the family members, particularly the mother-in-laws and the husbands, who often the decision makers in a country like India, with reference to her access and reach to the kind of care what a woman gets. So that was really useful. And during the study, we identified certain levels of knowledge and practices and their perception, which were really helpful in designing, or should I say, adopting the tips intervention to a locally contextualized manner. So we conducted about 3 to 4 focus group discussions with the mother-in-laws and 3 to 4 with the husbands. And so I'll talk about the challenges in the subsequent question. These were the key aspects. And when it comes to intervention aspect, we also involve family members as a part of the package. So proactive involvement of family members did boost pregnant women confidence, that entire family was taken into confidence, and that ensured better success rate and sustainability of the intervention what we expected, and that probably led to improvement in the intervention arm when compared to control arm. So those are the brief answers to those 2 questions, and happy to take up any question at the end. Thank you.
Thank you so much, Dr. Shivalli. Tulani, I will turn it over to you.
All right, thank you very much. So just describing the context of this research. So we conducted formative study in Zambia, and I think, as some of you are aware, Zambia is one of the countries that is still facing high numbers of mother-to-child transmission of HIV. So we conducted formative research using trials of improved practices, or TIPS for short. So we used to call the study the TIPS study, and our aim was to really assess the acceptability of engaging family members to support recommended infant feeding and early child development practices among women living with HIV. The study was conducted within 2 health facilities in Zambia's capital city, and these 2 health facilities have high volumes of mother and child visits. Course 1 being a level 1 hospital. A few years back, it was a health facility, just a clinic, but now upgraded to being a level 1 hospital. And the second one is still a clinic. So participants were enrolled to be in the study for about 3 to 4 weeks. So we asked them to invite 1 to 2 family members of their choosing to participate in the study as a home support, where they received counseling on care and feeding practices. And we followed up with them to hear about experiencing these different recommendations that we asked them to practice. So both the mothers were given practices to try out for about 3 to 4 weeks, and also their home supporters. And then during the exit interviews, we just sort of asked them how they experienced the recommendations, and if there's anything challenging about them, and what they liked most about those practices, and if they thought that this practice would be feasible for the rest of the community. So we wanted to hear in terms of what worked, what did not work, and sort of get feedback from them in terms of going in the future, what they also would recommend in terms of designing a larger trial or intervention. So what worked well in the process of conducting research with family members? First of all, given the fact that family members such as grandmothers, male participants, are very influential actors in making household decisions, and looking at all these different roles related to child practices, in the African context, I believe in other contexts as well. So when such home support is involved, it was easy really for them to stay engaged throughout the duration of the study, because other family members were aware that they were taking part in this study, which was going on for about 3 to 4 weeks. And secondly, asking them to involve family members enhanced the support they needed. So the fact that we asked them to sort of identify a family member for the whole duration of the study, I think for them, this was sort of enhanced the support they need, so that I think most of the women felt that they really had this support system within their own families and within their own communities at large. So it also really worked well when we mentioned that we would require that they identify a home support of their choice. So I know some studies require that the home support or another person be part of the study be maybe the male partner, for example. Some studies specify, but for this one, we sort of gave them the choice of identifying who they thought was the best person to be a home support. So really, it really worked well, because we didn't assume that the male partner or the grandmother is the best support system, but really we gave them the choice to bring along this home support, whether the grandmother, sister, and the male partner, an uncle, or anyone within the family. And so this choice also enhanced and was able to keep them engaged throughout the study. And also adding the fact that also female family members additionally provided great support system to the mothers as well. For example, the grandmothers, aunties, and also sisters. So we also provided the choice of doing the interviews in the comfort of their home, where they'll be comfortable. And almost 50% of our participants invited us to their homes to go and do an interview, because they're more comfortable us following them home. And this provided them an opportunity to come. And also, they were able to come on a date that they felt comfortable with. So we didn't just enroll them upon the first visit, but we gave them the choice to say, should you need to seek permission from any family member at home, for example, your male partner or your own mother, you can go and ask them for permission. Then on a date that you are comfortable with, you can come back for the enrollment interview, or ask us to come and conduct this interview at home. We also provided a choice of this. So also provided a recommendation how to improve feeding of infants. So there was a lot of appreciation for this information that we are providing to both the mothers and their home support, who was either a male partner, aunt, an uncle, or a grandmother. So they appreciate the fact that we provided this information. And lastly, looking at male partners, because male partners in most cases feel that breastfeeding is left to the women. So the fact that we're able to sort of give them the confidence that male partners also have a greater role to play in breastfeeding practices, I think also enhanced also their confidence. And from the exit interview, we were able to tell that they appreciated the fact that they were part of the process and not left out in the research. So I think those are some of the things that really worked well in the process of conducting the Trials of Improved Practices study here in Zambia.
Wonderful. Thank you so much for that. And I think now we will turn it over to Max.
Thank you, Neha. So apologies, I'm going to be having my video off because of bandwidth concerns. Our research context was within a program, a USAID-funded development food assistance program in Western Zimbabwe, which ran from 2013 up to 2020. It was implemented by a consortium of NGOs that was led by CNFA. So our program's formative research, which also was following the TIPS framework, showed us that women had good knowledge of the recommended infant and young child feeding practices. However, several factors impeded the sustainable adoption of the various behaviors and practices. Some of these emanating from culture and tradition around gender roles, work burden at home, issues of chores, some religious, and also some emanating from household members who were older and more influential, like mothers, mothers-in-law, aunts, etc. At the same time, that tips showed us that we had a potential facilitator for change in fathers, but we did not know how to engage men. So when the program started, we used an operations research in a formative way to inform our male engagement program. So in our research process, we spoke to married women and asked them what support they would want from men. This was done thematically, of course. That is, women would tell us the support they would want from men so that they could exclusively breastfeed, the support they would need so that they could continue breastfeeding up to the recommended 24 months, support in water and sanitation and hygiene issues, support with child complementary feeding, etc., etc. So when we developed this list of recommended supportive behaviors, we took this list to married men who had children under the age of 5. And we asked these men to rank the suggested behaviors by women, of course, along the lines of adoption potential. And in so doing, we ended up with a continuum of behaviors that showed us what men were not willing to do at all, what they might do, and what they were definitively willing and able to do. So we then moved on to focus on the intersection points between the views of the men and women. In other words, a focus on the behaviors that were wanted or suggested by women that men clearly stated they were willing and able to do. Regarding what worked well, in my view, I think this was having multiple layers of inquiry within the formative research. So the first layer, the tips, essentially showed us the factors or determinants and barriers around the adoption of various IYCF recommended practices. And it also mapped out the key individuals at household level that we could leverage on. Secondly, having a consultative way to select what to promote, I believe it gave the program a good poise for potential success by focusing on what was feasible and potentially attainable. I think in a nutshell, this describes what we did.
Thank you so much for that. And I think now we'll move on to the second part of questions. So now we would like to hear from you all, speaking on some of the challenges you may have faced related to the process of conducting research with family members, and what would you do differently in the future? So again, I will turn it over to Dr. Shivalli. Thank you.
Thank you, Neha. I hope you can hear me. So in terms of challenges, what we faced, again, I'd like to divide because our research had two broad components. One is the assessment and the intervention. So the assessment, which is mainly a formative research. So initially we had difficulties in convincing the family members that, they need to come and participate in the focus group discussion. They were not so interested, or some are hesitant, or some are reluctant. So we really had to be patient and persuade them that how their participation is very important for us to design the intervention. And with a lot of effort, then finally we could convince them to come and participate. And the next challenge was, though many of them agreed, but on the day of FGD, many did not turn up. I mean, we had fixed a minimum number of 7 to 8 per FGD so that we can successfully generate some group discussion. So that also did not happen. So we had to cancel about 3 to 4 FGDs and again go back to them and tell them that, it is really important, and request them to come. And we really need to adjust according to their time. When they are free, we started conducting FGDs. For instance, most of the men are free at the evening, so they were ready to come. So we had to work out of the our routine, our work hours. So that was another challenge. But eventually, we got them to participate in the FGD. And next challenge was some of the inherent challenges of the FGDs. When you do a group discussion, few of the women were dominating the discussion. So such things were also needed to be sought out, that we hear from all the participants. So that was another challenge. And when it comes to the intervention part, again, when the intervention was designed such a way that it included interpersonal communication with the pregnant women in the presence of family members, either a husband or the mother-in-law, whoever was present. But one of the problems was whenever we visited, none of the family members was available. So again, we had to really adjust according to their availability and fine-tune our visits whenever they are available. And once they were available, we were not so interested. They thought that it is not relevant to us. For instance, if I started explaining the importance of IFA and nutrition intake to pregnant women, along with the husband was not so keen to listen, or not so interested to proactively participate or help pregnant women do that, because pregnant women was openly sharing some of the challenges. For instance, why she has reduced intake since she has become pregnant. So she was sharing some of her really difficult practical experiences. For instance, in typical rural setting in India, most of the cooking is done by the woman. When she becomes pregnant, when she is cooking, the smell of the cooking is so much and it is nauseating. She doesn't feel like eating the same food after cooking. So that was a really practical issue. We simply say that, you need to increase the intake, but in real scenario, she can't, because the nausea takes over her appetite. So we tried to understand. We also adopted positive deviance approach. We tried to say what worked in other family, can you try that also? So that worked. So when we were explaining, some of the family members were initially not so interested. So that was another thing we had a challenge. And we really had to be very culturally sensitive to saying something. For instance, whether the family is okay to take the non-vegetarian food, and what are their cultural practices. So there were obviously prevailing misconceptions which we tried to address, but in a culturally sensitive way. So that's another challenge we had to face. So these are some of the major challenges what we faced while doing that formative research and the intervention part, while involving the families. What I would do differently in future, I would cover it in 3 points. One of the limitations was we focused only on pregnant women, but if I had to redo the same study, I would extend it to postnatal period, because that is equally important, where again she is supposed to take 100 iron folic acid tablet and also increase her calorie and protein intake. So I would extend it, make it a comprehensive package right from pregnancy till the first 3 months of postnatal period. So that's the first thing. Second thing is to go for a more robust study design. It was a quasi-experimental study what we did, and we could consider it as a pilot study. So if I had to redo, I would definitely go for a more robust design, like a cluster randomized trial, and test it in a better way and see whether it works or not. And third one is sustainability. How do we address, as I said, include it over a period of time so that you can test it, whether these behavior changes are sustainable over a period of time. So, and obviously include different geographical locations, because India is such a diverse country. The cultural practices have a strong influence on the IFA intake and the nutritious intake. So I would definitely include 2 or 3 different geographical locations that would address the diversity. So yeah, these are some of the challenges what we faced and what I would do differently in future. Thank you.
Thank you so much, Dr. Shivalli. I think many of us who have done qualitative research can relate to some of those challenges you shared and can appreciate some of the things you mentioned regarding what you would do differently. I will now pass it on to Tulani.
All right, thank you, Neha. So looking at some of the challenges that we experienced, I think first of all, involving male partners in research, I think those that have done qualitative research will agree with me that it sometimes it's a challenge. And look, for us, we discovered that most of the time men were busy and hadn't had time to really sit down with us, for an interview, allowing us to, of course, to provide them recommendations and then maybe come back at some point and sort of hear their experiences. So in some cases, we made attempts, but sometimes it really didn't work. So this really, for me, I feel it tells us a lot that it may be challenging really to engage some family members more than others, especially male partners, unlike it is to engage other family members, female family members like grandmothers, aunties, and sisters. So I think something a bit to take note as we continue to do research. And the secondly, it has to do with more status disclosure, because we were doing research with all our participants, all the mothers were living with HIV. So in some cases, very few cases, of course, their male partners were not aware of their HIV status. And of course, ethically, we didn't want to be the ones to cause this misunderstanding within the family. So once, a mother told us or informed us that she has not disclosed HIV status to the home support, would be in that case maybe the male partner or even another family member, we could not proceed to enroll that family member because they were not aware of her HIV status. That was a challenge that we faced. Another challenge that some women, very few of course, had some challenges in identifying home supporters. In some cases, some home supporters were not available to provide the support that they would need. And of course, the home support, a home supporter was a very important criterion for women or mothers to be part of our study. And I think one of the other things is that information in some cases, because we first of all get feeding practices from the mother, hear what is happening at home, and also hear from the home support, from her home supporter. So sometimes you find that information is not the same regarding what the mother is giving the baby at home. So in some cases, the mother will mention that she's exclusively breastfeeding and not giving the baby any other foods or any other liquids, but the home support would actually disagree to say there's sometimes when the baby is given maybe orange juice, maybe water, or cooking oil, for example, for colic. So that's one of the other challenges. And then the last one, I think for me would be because we conducted this, study amid the pandemic. So when we started, we enrolled for a bit. Then we were asked to sort of discontinue our studies due to the high numbers of cases in the country at that time. So we went for almost a month plus weeks, without keeping in touch with our participants. So during this particular period, we lost quite a number of participants. and it was difficult. Of course, once we resumed, it was a challenge for us sort of, get back to them and continue from where we had left the discussion. So we lost quite a good number of participants in that way. So what I would do differently in the future, I think relating to the challenge where we received quite, varying information from the mother and the home supporter. I think maybe it would be good to have interviews separately, but maybe one visit where we talk to both the mother and the home supporter at the same time, sort of get an understanding of some of the infant feeding practices at home and what they both think about those practices at the same time in maybe one sitting. And the secondly is what I would do is sort of develop these different strategies or intervention recommendations, sort of using a participatory approach. I think as someone with a social science background, I'm one person who believes, sometimes good for the community to develop interventions that they feel they can work with. So I would sort of, at some point, use an approach where the community comes in and has a say, or maybe play a role in how we develop some interventions, getting feedback from them as we are developing the interventions or recommendation that we later provide to community members. And also one of the, regarding the challenge with male partners, I think most of the, looking at the communities where we enrolled our women, these are from densely populated communities. And so the male partners are really involved in the informal sector, where they do quite a lot of labor-intensive work. So because of this labor-intensive work, or doing different pieceworks to earn an income, I think that also hindered them from really finding time to be fully engaged in the study. I think from what we noticed that a number of male partners were really willing to part of the study and to be engaged in infant feeding and also learn some feeding practices, but I think some of their jobs would allow them to be fully engaged in the study. So maybe next time we could maybe work with men that are in the formal sector that might maybe have a little bit of time and just see if that would work out differently. And lastly, I think because we conduct this study in Lusaka, Zambia's capital city, an urban area, it would be good to also go and conduct the trials of improved practices in the rural areas. I think earlier one of the one of the speakers had mentioned to say, when it comes to feeding, there are all those norms and cultural beliefs and all these different things. It would be good to also get it from conduct stuff in practices in the rural areas or within rural communities where cultural practices are really strong, and see if results that we get from rural areas and urban areas will be the same or different. Yeah, I think that would be all from me. Thank you.
Thank you so much, Tulani. I think you touched upon many different points there, and it looks like it generated a few questions and responses. So thank you again for sharing. And I think now we will turn it over to Max to end the question portion of this panel. Over to you, Max. Thank you.
Thank you, Neha. So in our case, administering the process was not difficult. The program at this stage was well accepted in these communities. So recruiting and engaging the participants for the study wasn't a challenge. Also, I believe because of the burden of nurturing children and childcare, women really wanted to talk about these issues. And this study offered them that opportunity. And they seemed to really want the help. So they spoke freely about these issues. However, the challenge that I saw, I believe, was in the process itself that we took. So we only looked at married men who were fathers in these communities. But fatherhood in these communities extended beyond being simply a biological parent. I believe actually worldwide this is possibly true, that fatherhood is perhaps behavioral rather than being a biological parent. So these communities would see fatherhood as a man who behaves as a father towards a child, and not necessarily being the biological father. Also, in these communities, households tended to be comprised of extended families rather than the nuclear ones all the time. So at the same time, you would find that men would spend protracted periods of time away from home. Bearing that in mind, a father then could be anyone, really. It could be an uncle who is there at the homestead. It could be an older male sibling. It could be a mother's brother or a grandfather. And as we implemented, we realized that in taking such a narrow view to fatherhood and therefore male involvement, we had left out a significant portion of potential program beneficiaries. And perhaps we had left out also a significant component of women, the mothers themselves, because we have got a high incidence of underage pregnancy. And usually in such cases, the absentee fathers are the case. We would also have cases where the caregiver is not necessarily the biological mother. And in taking this narrow view, we had essentially left out the voice of those women as well in the inquiry. So what I would do differently, I believe from the onset, I would take this broad view of fatherhood. And I would also add more layers to the inquiry to focus on mapping the intra-household social dynamics around the decision-making on child feeding and health. So I believe this will help us to better understand the social networks intra-household that govern the choices around child feeding and health. And in so doing, this will help us to map out the key family members we need to engage with in order to promote IYCF and bolster potential outcomes for children under the age of 5. Over.
Thank you so much, Max. I think you addressed many different areas there, and I look forward to the discussion that will come after that. I will like to thank you all once more for speaking. I think your responses were very informative and comprehensive, and now I think we will turn it over to you all to answer questions, and please feel free to unmute and speak out on questions. I do see that there's some in the chat. Please continue to share them in the chat. And we will start with the questions that have already been shared out. But again, please feel comfortable to unmute and voice any questions you may have. And I will turn it over to Dr. Stephanie Martin to facilitate this session. Thank you.
Thanks, Neha. And thanks everyone on the panel for sharing your experiences. One of the first questions is from Cam, and the question is, From your experience, do you find that family dynamics and involvement vary a lot between different global cultures and regions? Dr. Shivalli, if you'd like to start with that question.
I think yes, but I can't comment on the other part of, I don't have any experience in the Africa or the US, but within India, I know that the dynamics varies. It's a diverse country, and it all depends on the education status and the family's interest in the involvement. So I would say yes, the family involvement dynamics does differ.
Thanks for that. Tulani, do you have anything to add based on your experience?
Yeah, thank you very much, Stephanie. I think, yes, family dynamics do matter, and also cultural dynamics, because I think there's some cultures here in the African setup that don't really encourage male involvement at that critical stage when the baby is too young and maybe looking at things to do with feeding practices. I think because of our cultural backgrounds, male involvement to many would simply be, providing financial support to the child. And at the same time, there are also some cultures that really encourage, male involvement at all levels, including when the child is born, the feeding practices and their own. So I think it does matter quite a lot.
Thanks. Max, do you have anything to add?
I'll be very brief. My experience is also limited to Zimbabwe, so I wouldn't be able to speak definitively about other setups in other countries. But I think it stands to reason that the social dynamic would be different, looking at the different countries. So then whatever follows, I think should also be different. Thank you.
Thanks. We had another question from Lori for Dr. Shivalli, asking what you see as the advantages of TIPS over randomized control trials.
I wouldn't say that TIPS would substitute RCT, but it definitely substantiates the RCT. It drastically improves the intervention, particularly the first part, the formative research part, where you adopt various qualitative approaches like FGDs and in-depth interviews and try to understand the community's perspective on the problem what you're studying. That really helps to contextualize the intervention, what you're going to implement, the local context. That's what ultimately matters, right? For instance, as I shared in my example, the practical problem, we tell women that you need to increase the calorie and protein intake or take one additional meal, but we don't understand from her perspective what is the exact issue. Those things cannot be addressed through quantitative approach, and TIPS approach gives that additional edge, to have a qualitative approach and understand their perspective. And another, similar experience with the iron folic acid intake. Most of the times, what we understood from qualitative aspect is she just doesn't remember to take that iron folic acid tablet because there is no reason, she just doesn't remember. So and the first week is very crucial. There is a lot of side effects when she takes iron. So the intestine cannot handle either. It most often ends with diarrhea or constipation. So that first 1 week is very crucial. So all such minute things can be picked up only through qualitative research. So that is the biggest advantage. And of course, when you design the intervention, once you involve the family, so that also added, I would say, an advantage from as far as TIPS is concerned. Yeah. Thank you.
Thank you. Tulani, there was a question from Lisa asking which family members women in your study chose to involve.
Okay, I wouldn't really point one because we had almost half. We had those that wanted the male partner to be the home support, So we had a good turnout of male partners that were identified as home support. And we know we had a good number of women that identified their own mothers. So I would say it ranges between the male partner and their own mother as no support. Of course, a few went with their sister and an aunt, but I think majority, I would say, went for the male partner and also their own mother or the grandmother to the child.
Thank you. All right, thanks everyone for writing your questions in the chat. And if anyone would like to ask a question, as Neha mentioned, please feel free to unmute and ask it. Timothy?
Hello, can you hear me?
Yes.
Yeah. I thank all the participants for their presentation, especially the presenters. This is a wonderful work they have been doing. Yeah, that's good. Congratulations. I want to go in the same line with Dr. Shivalli. This is the problem we are facing in Ghana. I tend to look at the religious beliefs also play an important role, especially when we're talking of IFA with pregnant women. Because in the district I'm working, in the northern region of Ghana, they are 95% are Muslims. And our data always show that anemia in pregnancy is high, especially at the age of 36 weeks. So I think we don't know whether religion, because most of them are Muslim, I don't know whether religion is also play an important role in that context, or there are other issues, though we don't have any studies that clearly show that what exactly caused it. But in our routine surveillance, we get to realize that the women, some of them, they refuse to take the IFA when they collect it from the routine services. They don't take it. Mm-hmm. Some are thinking that, according to the feedback we are getting, some are saying that it makes their speculations, they make their children, their fetus to grow fat, and the delivery is a problem for them. And we have been educating them. There is no scientific basis that shows that when you are taking IFA, you deliver a bouncing baby, a big baby that will be beyond your, or maybe your uterus can contain. And others also are complaining about the nausea. Like when they take it, some of them are not feeling comfortable. We have also explained to them the side effects when you are under IFA. We have explained the side effects. So others will come and so now what we have adopted, when you come for antenatal, and the health service personnel give you, you have to take it there. For some that are supposed to take, at least the other ones that the weekly or daily taking one, you go, and we always advise the what do you call it? The husband or the grandmother. We are also now continuing educating them. We're still educating them at the family level. So when your daughter-in-law brings back the drugs, make sure that she always takes it. So I believe those dynamics, I would have been happy if a doctor will share more light on this. The study is very interesting comparatively to my area of operation, where I am in the northern part of Ghana. The anemia in pregnancy is very high. This is the only challenge that we have, especially. Thank you very much.
Yes, can I respond to that?
Yes, please.
Yes. Thank you for that really excellent question and sharing your experience. I would say it as misconception. I don't know whether it is, it could be attributed to religion. In fact, the one reason what you shared, taking additional food during pregnancy would increase the size of the baby, and that would make the normal delivery difficult. The similar observations we made in India in our study, in our research also. So that's why I said, TIPS has an advantage. Such things cannot be picked up by quantitative approach. So we need to have a qualitative approach. Similarly,
Okay.
regarding IFA, iron folic acid comes in, it's a brown color, right? Obviously. So there was a misconception that taking brown color tablets make the baby brown. So I don't want to take that. And there was a misconception that, before pregnancy, woman was eating non-veg, but after conception, somebody told her she stopped. So there was a drastic reduction in her protein and calorie intake. So all these are misconceptions, I would say. They could attribute it to anything, that could be simply passed on to generation or simply prevailing in the community. I don't know to what extent we could attribute it to religion, but definitely such misconceptions are there. And we need to address by adopting, first we need to identify them through qualitative approach. And when you identify such issues, we need to incorporate possible solutions in the intervention package what we design. So maybe we need to understand why they do so and clarify their misconception and try to maybe adopt a positive deviance approach. As I said, the other pregnant women in the same area changed in this way. So if you can also try in the same way. So this is what we did. So that really helped. And obviously taking confidence of the family members would really make a significant difference. That makes things very easy for the pregnant woman to implement, because she need not have to explain to the husband or the mother-in-law what she is doing differently, and it also ensures the sustainability. Yeah, thank you.
Thank you, Dr. Shivalli. I'd like to try to get in one last question before we finish up. There's a question from Marcia Griffiths. Looking at how to engage family members and wondering if you have thoughts on whether women relating their experiences is of interest and useful in engaging family members. She mentions that Max touched on this, but she'd be interested in hearing others' experiences. Maybe Max, if you want to say a little bit more about when family members hear about women's experiences, and then we could turn it over to Tulani.
Okay, thanks. So I think there is a lot of value in getting the voice of women, because the way that we did it at the end, we promoted the things that women wanted. And I think that is a plus. And also to show the value of taking this view, when we evaluated this program at the end, sadly, we only managed to evaluate on one thematic area, which was exclusive breastfeeding. We found that women whose husbands were exposed to this campaign were 4.7 times more likely to exclusively breastfeed the recommended way than women whose husbands were not exposed to this campaign. And I would wager that the winning ticket or game changer in this was the women's voices. Over.
Thanks for that, Max. Tulani, do you have anything to add?
Yeah, thank you, Stephanie. I think definitely, listening from the women's perspective is a game changer, because I think at the end of the day, we sort of wanted to ensure that the woman gets the support that she needs to exclusively breastfeed. And of course, if there's things that she's not being supported on in terms of not being able to fully breastfeed, then listening to her and also being able to give her the voice enabled other family members to be able to provide the support that she would need. I'll give an example, like I think I'd mentioned, to say in some of the male partners we talked to, never knew that they could play a greater role in maybe encouraging the mother to breastfeed the baby, or just doing other things that can help her breastfeed, like making her comfortable, or just using words of encouragement to give her confidence. So it was very interesting that once we told them this, I think they played a greater role, because once women voiced that this is the support that they need and delivering it to the male partners, that they should practice, encouraging the baby's mother to breastfeed and praising her every time she does something good, was a plus in that aspect.
Thank you. Dr. Shivalli, do you have anything to add as well?
I think I completely agree. Sharing women's experience that definitely with the family members has an impact. In fact, as a part of intervention package, we used to do interpersonal communication in the presence of either husband or mother-in-law, and we realized that the pregnant woman used to tell her some of the problems which she never had an opportunity to discuss with the family members. So when she opened up all those problems, quite often the family members came with the instantaneous solution that was really helpful, which could be easily adopted and implemented at her house. And since the family member is supporting, that was really sustainable. So I think, yeah, it is really important to share the pregnant women's experience with the family members.
Thanks so much. Neha, do you want to, I'll turn it back over to you to close out our session, but thanks everyone for sharing your questions and experiences in the chat.
Yeah, it looks like we're at time, but thank you again to everyone for joining our session on formative research. Numerous points were discussed, including challenges of utilizing a qualitative approach, extended family structures, responses, and difficulties with engaging all and multiple family members at once. But we would also really like to thank everyone for your questions and responses to this discussion. And once again, a huge thank you to our speakers, Dr. Shivalli, Tulani, and Max. We will follow up soon with more information on meeting 4, which will take place mid-July. But before leaving, please take a moment to answer the Zoom poll question that should have popped up on your screen. But thank you so much again to all of you. We hope you can join us for our next meeting, and take care. And I hope you all have a wonderful rest of the day. Thank you all so much.
Thank you, one and all. Bye-bye.
Thank you.
Thanks.
Bye.